the Sri Lanka College of Internal Medicine for inviting me to give this lecture. The topic given was the diastolic heart failure, but I had to make a correction because if you see the literature, that we don't call the diastolic heart failure anymore. We call it heart failure with preserved ejection fraction or normal ejection fraction, because the reasons I will discuss later. Because all the new literature call them heart failure with preserved ejection fraction or with normal ejection fraction. Epidemiology-wise, approximately 50% of the heart failure patients you see in clinical practice will belong to this category. And compared with the patient with heart failure and reduced LV ejection fraction, individuals with heart failure with normal ejection fraction are typically older and more likely to be women. There is the prevalence of hypertension is very high in this population. Almost 88% will have hypertension. Obesity is another common observation we make. Renal failure, anemia, atrial fibrillation are known associations. And the prevalence of diabetes is about 30%. And the prevalence of coronary artery disease is fairly high, about 40 to 50%. So we have to screen for all these if you come across a patient with heart failure with preserved ejection fraction. When you compare the signs and symptoms, except the third heart sound and cardiomegaly, all other signs and symptoms are that of reduced ejection fraction, but you see. But if you do a chest X-ray, most of these patients will have a normal heart size. I will discuss that later. The definition-wise, you can see the current definition. Define heart failure with preserved ejection fraction. All of them should have some symptoms and signs of heart failure, and the ejection fraction should be equal or more than 50%. And there is an additional criteria that objective evidence of cardiac structural and of functional abnormalities consistent with the presence of LV diastolic dysfunction, raised LV filling pressures, including raised natriuretic peptide. So this criteria has to be fulfilled for the diagnosis. So what does it consist of? That is, first is LV mass. That is left ventricular hypertrophy. If you do echocardiogram, if there is left ventricular hypertrophy, you can say that there is increased LV mass. But although presence of concentric left ventricular remodeling or hypertrophy is supportive, the absence of left ventricular hypertrophy will not exclude the diagnosis. And the LA volume or LA size, you can measure the LA volume, LA size by echocardiography. Because if the left atrium is enlarged, again, it is supportive of the diagnosis, but absence of that will not exclude the diagnosis. Other one is the E to E prime ratio. I will discuss how to measure it in the echocardiography or POCUS. Its sensitivity, specificity is about 59%, but if they increase the cutoff point to 13, then the specificity increases. But again, that alone will not diagnose give a diagnosis. So raised pro-BNP or BNP level again will support the diagnosis, but again, you must remember, 20% of the patients with heart failure with normal ejection fraction can have normal BNP levels. Other one is a PA systolic blood pressure. That is, you can measure if you have a tricuspid regurgitation in the echocardiographic examination, and the specificity is about 85%. Now the pathophysiology of heart failure with preserved ejection fraction is, you can see you can compare these with an Olympic athlete. So go from the bottom. They both are breathless. The Olympic athlete is after a long run. They increase lactate levels. Both will have raised LA pressures and insufficient cardiac output for metabolic demand One is because of very high exertion, other one is with a very mild exertion. The only difference they have is a very low workload with a heart failure with preserved ejection fraction in the Olympic athletes. And see the pressure volume curves. On the left side, you see the patients with heart failure with normal ejection fraction, where filling pressures are contributed by the venous return in the heart and pulmonary venous return. So if you get a level of filling pressure A, for a patient with heart failure with normal ejection fraction, the left ventricular volume is low. So with a low volume, they have high pressures. If you look at the Olympic athletes, they have a similar pressure, but they have high left ventricular volume. So how they can increase the volume? They exert, or usually the venous return increases. So the filling pressure B with exertion, you can see the patient with heart failure with preserved ejection fraction can increase the volume only a little bit because their ventricles are stiff. And but the Olympic athlete, of course, they can increase the left ventricular volume by a small change in the filling pressure. So it is very elastic, and they can accommodate more volume with less pressure changes. And the stroke volume, again, it's connected to both. So the stroke volume will be very high in Olympic athlete with the same pressure changes when you compare with the heart failure with normal ejection fraction. So you can see the heart failure with normal ejection fraction people usually have a small left ventricular cavity with left ventricular hypertrophy and non-compliant left ventricle. But if you have an athlete or very active person who will have a large ventricular cavity, more cardiorespiratory fitness, and the lowest possible of getting a heart failure with preserved ejection fraction. So it's all mainly related to the sedentary lifestyle as well. And how these things then happen? Now, in the molecular level, now if the risk factors are there, then of course it affects the TGFP1 collagen synthesis and the MMPS enzyme activity. These led to increase in the arterial stiffness. So that will cause increase in the systolic pressure and lowering the diastolic pressure. Most of these patients will have a wide pulse pressure. And that causes impaired LV systolic deformation. You can see, although their systolic function looks normal, their systolic function is not normal because heart has 3 types of contraction during the normal. It's a horizontal contraction, longitudinal contraction, and rotational contraction. So what you see in the echocardiogram is just a horizontal contraction. So there is some systolic dysfunction with these people. So that's what we don't call it a diastolic heart failure anymore. And there is also impaired coronary microcirculation in these people, and that can cause ischemia. So this causes the increase in the stiffness of the myocardium, and that lead to high end-diastolic pressures and left atrial pressures, and they get heart failure. If you see the diagnostic algorithms of these 2 algorithms, what you see in the left side is the American algorithm, and the right side is the European algorithm, where once you suspect a heart failure, you have to do natriuretic peptides in the European guideline. But again, in Sri Lanka, natriuretic peptides are not widely available. And so you have to go to the 3rd step. That's what the American College of Cardiologists says. That is, if the natriuretic peptides are not available, go for transthoracic echocardiogram. Now, natriuretic peptides are often elevated in heart failure with preserved ejection fraction and are predictive of outcomes. So the level of natriuretic peptides will, we can give some idea of the outcome. The more the level, the bad the prognosis. And the next important thing is the focus. That is, if the natriuretic peptides levels are, if you can't measure, then you have to go for echocardiography. This can be done very easily as a focus, and I will just go through it very quickly. So what you have to demonstrate is the E to E prime, prime ratio, the structural abnormalities of the heart, and also you can use a scoring system end of it. Now, this echocardiographic picture shows, now the first picture shows there is left ventricular hypertrophy in this patient, but there is not much of left ventricular atrial enlargement. And the right upper cartoon explains how do you measure the E to E prime ratio. That is, the first, you have to measure the mitral inflow velocities with the pulse wave Doppler. That is the left lower corner one, what you see. There you can, it's a mitral inflow pattern. There you can measure the early velocities with a pulse wave. That is one measurement. Other one is a tissue Doppler. Now, tissue Doppler, you can just push of a button, you can change the mode to tissue Doppler in new echocardiographic or ultrasound machines. And there you have to interrogate the lower basal septum in the annulus or the lateral wall. You can either measure one of those movements. When you measure the movement, you can get again the E prime ratio. There is, you can see the E prime ratio is measured. That this patient is about 28. So if it is more than 9, it is significant. And if it is more than 13, your diagnosis becomes more apparent. And also not only that, you have to look for increased pulmonary artery pressures that you can do with, if there is a tricuspid regurgitation in the echocardiogram, you can measure the tricuspid valve velocity. Here the velocity is about 48. Normally anything more than 40 is significant. You can say they have pulmonary hypertension. The left upper corner shows a dilated IVC. So if there is a dilated IVC, there is increased volume or fluid overload in this patient. And also the lung scan, you can see on the left lower panel, that is the B-line artifacts, that you have to look for that. And if you see those B-line artifacts, you can say this patient has pulmonary edema. And also in a worst case scenario, you can also demonstrate pleural effusions just with the cardiac probes. These are all done with the cardiac probes. You can, with a normal ultrasound probe, you can get better pictures. And it can be done in bedside with these patients. So once you do that, you can apply the scoring system. If you are not sure, but sometimes it's obvious, the diagnosis is obvious, no need to go for the scoring system. Otherwise, look at H2-HFpEF scoring system that include the obesity, hypertension, atrial fibrillation, pulmonary hypertension, in older patients, and filling pressures. They all you can put, and you can, if anything more than 5 will supportive of the diagnosis. And in the process of diagnosis, you have to exclude other causes of heart failure with preserved ejection fraction. That can be cardiac causes or non-cardiac causes, like cardiac causes like coronary artery disease, valvular heart disease, HOCM, restrictive cardiomyopathy, constrictive pericarditis in intracardiac shunt, and non-cardiac causes like lung disease, obesity, deconditioning, anemia, hyperventilation, thyrotoxicosis, and extracardiac shunts. So a simple approach to diagnose heart failure with preserved ejection fraction is signs and symptoms. Ejection fraction should be equal or more than 50%, elevated BNP level, and evidence of structural heart disease in the heart like LVH, left ventricular hypertrophy or left atrial enlargement, exclusion of other differential diagnoses. Now, treatment-wise, you can see the heart failure with reduced ejection fraction. We have a lot of evidence-based medications like AC inhibitors, ARB blockers, mineralocorticoid receptor blockers. You can see all these are studied with heart failure with preserved ejection fraction. You can see there is no significant benefit of these drugs in heart failure with normal ejection fraction. When comparing with heart failure with reduced ejection fraction, there is a huge benefit using these medication. Again, the Paragon heart failure trial, which is done with a sacubitril valsartan, that's a new entity used in heart failure with reduced ejection fraction. Those who are resistant for the other treatment, shown to be very beneficial. Again, this trial also failed to demonstrate that it is significant, but you can see the significance, it just missed the significance. Its p-value is 0.059. So if it's 0.05, it would have been significant. So these are the problems with the clinical trials. You have to we have to interpret it carefully. And the new medications, which SGLT2 inhibitors, the anti-diabetic medications, have shown to be effective in heart failure with reduced ejection fraction. These medications were tried and in several trials, two trials which have recently published, that is Emperor Preserve trial, and fortunately, these two trials have achieved a significant level, and you can see there the cardiovascular death or cardiovascular hospitalization, the hazard ratio is 0.75, so it reduces the risk by about 21%. And again, the next study, it's a DELIVERS trial. It's done with dapagliflozin, and again, it reduces the heart CV death or worsening of heart failure by about 19%, again, about 20%, and number to treat to save a life is 32. If you see the meta-analysis of all these trials on SGLT2 inhibitors, again, you can see all these medications without fail showed that whether it is the reduced ejection fraction or preserved ejection fraction, the benefits were there in reduction of cardiovascular death or heart failure hospitalization. If you take only cardiovascular death, the benefit was not like the primary outcome, but is again about 18% reduction in cardiovascular death patient with heart failure. So that's the reason the current guidelines, the treatment of heart failure with preserved ejection fraction, mentioned the diuretics are one of the important medication because these people are fluid overloaded. So you have to use diuretics as a first-line drug. That is a class 1 indication. And the SGLT2 inhibitors, because of these two trials, in a 2A category. And other medications like valsartan, sacubitril, that is a neprilysin inhibitor, that 2B, and mineralocorticoid receptor antagonists, again 2B, and angiotensin receptor blockers are also given as 2B indication to treat this patient with heart failure with normal ejection fraction. Prevention-wise, it's important to prevent this heart failure with ejection fraction, and we can prevent it. If you effectively treat hypertension and reduce the left ventricular failure, again, you can prevent heart failure with ejection fraction. And if you come across any diabetic patients with hypertension, there is indication then, of course, use SGLT inhibitors as the first-line drugs to prevent heart failure with preserved ejection fraction. If the patients have coronary artery disease, you have to optimally treat patients with coronary artery disease with medication, and those who require revascularization, you have to revascularize them. And patients with high-risk categories, if you want, you can screen them with natriuretic peptides. Is recommended as a 2A recommendation. And also, you can use validated scores to assess these patients' risk of getting heart failure with reduced the preserved ejection fraction. Thank you.